Okay, so I think we are ready to go. As you may know, I'm Maria Pellegrini. I work for the ERN-EuroBloodNet European Reference Network on Rare Hematological Disease, and I coordinate educational project and patient-centric project. So I'm very pleased to welcome all of you and to this fourth session of a webinar program consisting of 9 sessions dedicated to aplastic anemia and PNH. It is named ERN-EuroBloodNet Topic on Focus on Aplastic Anemia and PNH. And it has been coordinated and co-decided in collaboration with the Patients Association, PNH Support, who is focused more on PNH and represented by Maria Piggin, who is also ePAG of the ERN-EuroBloodNet, so she represents at European level the patients community, and also with the representation of Pascale Olivia Burmester, the association Lichterzellen, who is more focused on aplastic anemia and PNH, and of course the PNH Global Alliance. And I really want to thank for their fruitful collaboration. So as you may know, this program really tried to disseminate in a wider way all the topical areas that are related to these two rare, or in the case of PNH, even very rare disease. And so we are going to see the medical services that are available in Europe, the recent quality of life, cutting-edge advances, the treatment option, and so on. And so today, indeed, we are going to talk about the treatment of PNH. So I'm very pleased to introduce the speakers who indeed will not need any presentation. So we'll have with us, as always, a duo consisting of an expert physician and an expert patient advocate. So with us today, we have Maria Piggin. Maria, do you want to introduce yourself as you told me?
Sure. Thanks, Mariangela. Hi, everybody. I'm Maria Piggin. I'm a PNH patient of more than 20 years, and I also started PNH Support, which is the charity supporting PNH patients in England, Wales, and Northern Ireland. I'm also the chair of the PNH Global Alliance, which is an umbrella organization for PNH patient organizations, currently with 10 members across 9 countries.
Thank you very much, Pascale. And so then we will have Professor Regis Peffault, who is currently working in the hematology and bone marrow transplant department of PNH Hôpital Saint-Louis here in Paris, in France. He's also in charge of the Reference Center for Aplastic Anemia and PNH and the French Network on Hematology, Immunology, Rare Disease, Filière Marie, and is also coordinator of a plastic anemia working group of the European Society for Blood and Marrow Transplantation. And finally, he's coordinator for bone marrow failure subnetwork for the ERN-EuroBloodNet. So please, Regis, I'm happy to pass the floor to you. Thank you very much.
Thank you very much, Mariangela. Thank you, Maria, for those kind introductions. So I'm very pleased to be here and to give you this talk. Basically, the idea of today was really to spend some time on hemolytic PNH. So, of course, as you know, PNH might lead to hemolysis and being the first stage signs of the patients, but we also have bone marrow failure associated with PNH. And that will be the next talk during the educational session. So I'm really focusing on purpose on hemolysis and PNH. So first of all, my disclosures. So basically, what we do know for patients, and we'll see in a minute which patients are supposed to be treated for complement inhibition. What we do know is that we have now eculizumab, and I don't want to recall the success story of that drug that really revolutionized the field. There is no other words, because basically, I mean, I remember perfectly when I was coming in as a resident in the unit, we were completely devastated facing patients with PNH. We have no other treatment than bone marrow transplant with all the morbidity and mortality that can be related to it. And anticoagulation was not enough to stop thrombosis in those patients. And then came through this monoclonal antibody, eculizumab Soliris, that was outstandingly important, developed by Pete Hillman in few patients, and then we randomized phase 3 trial showing a drastic and astonishing improvement in our patients in terms of intravascular hemolysis blockage and in terms of thrombosis protection, and in the end, in terms of overall survival. So basically, and that I think one of the most important message of this talk, basically what we do know is that here is represented the complement cascade. So what does it mean? It means that this is basically what is wrongly activated in PNH on the left side of the slides, which is wrongly activated because those diseases don't have any inhibitors, any complement inhibitors. And what we do know is that the complement is constitutively activated in our body. We are constitutively, permanently protected against infections, against autoimmune reactions, and all these things are coming through in continuous, constantly, permanently, because of the complement activation. So the moment that we are speaking right now, you have the complement that is trying to reach out infections to be sure that we don't have any fever or any infectious problems. And as you can see here, this is a complex system with many, many molecules that are involved. And basically, to protect the body, we have to activate all those molecules from C3 to C5, and then to the creation of what we call the complement attack membrane that is able to destroy the cells. And basically what we do know in PNH is that all this cascade is wrongly activated because we don't have inhibitors. And what is doing eculizumab is to block at the terminal level. You can see that I put terminal, proximal. Basically the terminal, it's the end of the activation of the cascade, while proximal is the early activation of the cascade. So basically, as you can see here, under eculizumab, and that's what is very important, under eculizumab, we have an early activation of the complement, and that is very important for the end of my talk when I will speak about proximal inhibition, where there won't be any early or late activation. However, under eculizumab, we were able to block the late activation of the complement. And as you can see here, we are blocking the complement at the C5 level. Eculizumab is an anti-C5. And so if you have an anti-C5, the complement cascade is not activated. And so, of course, your cells are protected. And the good thing of it is that you are with this level of blockage at the terminal level, at the late phase of the complement cascade level, you are conserving your protection with C3. You have the early activation of the complement, so you still have a immune complex clearance, a infectious protection, so you still have some functions that are still working. So that's the way that eculizumab is working, and as you can see here, under eculizumab, this is what is important to understand. We still have an early activation of the complement, while the late phase of the complement is not blocked anymore. So, I mean, eculizumab was a very nice story because when we were coming back on real life data, so in other words, when we were looking on patients who were in real life, we were reproducing exactly the results that have been published in the randomized phase 2 trial. And that's what we are always saying as a physician, is that sometimes, since we are doing some very clean studies, the trials, the inclusion criteria are very strict. It's quite difficult to reproduce all the benefits we observe in the effective clinical trials in real life. And I can tell you that with eculizumab, there was a UK experience, afterwards the French experience. What you can see is that in the treatment, the overall survival of patients under eculizumab was outstanding. He was joining the overall survival of LC controls matched for sex and age, meaning that under eculizumab, patients with hemolytic PNH were almost, or I would say, were having the same overall survival than patients from same age and same sex, but not sick. So that's exactly what we also reproduce in France, as you can see here, and what we did show, but the UK people did show the same, or we did show the same because we published after, but basically what we did find is that eculizumab was associated with a better overall survival in a cohort of patients with hemolytic PNH. And it was really a revolution in our hands because, again, we didn't have any products or drugs that were able to improve the expectancy of our patients and protect them under thrombosis like eculizumab was doing. So now we come to the point of when a patient should be treated. And basically, I put it here because in the middle between proximal, so the proximal blockers we'll see in a minute, and the terminal blockers, that is eculizumab, that has almost 15 years of age, because basically the indication for treatment is always the same, whatever the treatment is. First of all, a patient with transfusing red blood cells because of hemolysis. So basically, patients who is receiving red blood cells because of active disease should be treated with a complement inhibitor. It might be eculizumab, it might be something else, but basically the patients should be treated because his hematopoiesis is not able anymore to support the destruction of the cells. So this is a major indication for treatment. The other indication is when you have some symptoms that we know are related to the activity of hemolytic PNH. So basically when a patient is presenting abdominal pains, dark urines, fatigue, or even some nausea, it means that the disease is active, and then even outside transfusion, the patients should be treated. The other very important indication for treatment is clearly thrombosis. And I would say this is the main indication that should not even be discussed. If a patient is presenting a thrombosis and a PNH clone, he should receive complement inhibitor. It has tremendous change the prognosis of our patients using this complement inhibition in patients with thrombosis. It's protected against a recurrence, and it's protected the survival of our patients. Finally, there is a fourth indication for treatment that I really put, as you can see here, a plus or minus, because it still needs to be discussed. It's the patients who are pregnant, because if you are pregnant but you have absolutely no signs of hemolysis, you may not benefit from a complement inhibition. And since once a treatment is begun, you have to continue it lifelong, I would say that basically you should not be treated. If a patient is pregnant and is presenting hemolysis, then the situation is different because the risk of thrombosis is very high. So we don't want to lose the mother of the kids or both. So that's the reason why pregnancy should be done under community. We showed in the New England paper with Richard Kelly that eculizumab during pregnancy was safe and efficient for both mother and kids. Something that is very important to me is that we are not treating biology. So in other words, it's not because a patient has a very large clone size that the patient must be treated. If the patient is perfectly asymptomatic, if the hemoglobin level is normal, there is no reason to treat. Okay, so I don't have any mic anymore, so it might be an echo, but anyway, if it's better, that's fine. So what I was saying is that we are not treating biology, and so that the clone size per se is not an indication for treatment. So in other words, if a patient have a 90% clone size, but has absolutely no clinical symptoms, is feeling great, is doing marathon, he has no problem, I would not treat these patients. Of course, we have to inform, we have to alert, we have to explain that if any symptoms are coming in, the patients might be treated. And we are giving vaccination to those patients with large clones but no symptoms to be ready to treat, but we are not treating them upfront because of the colon size. The same with LDH. It's not because you have a high size of LDH that we are treating patients. This is not a marker per se that should indicate a treatment. Again, we have to look for clinics, transfusions, clinical symptoms, or thrombosis. The last point, but not least, because we have some discussion at the expert level, is obviously what we should give to our patients under treatment. So as you can see, when we are blocking the complement, since the complement is what is protecting us under infection, we have to vaccinate our patients. So we all agreed on that. Patients should be vaccinated to be protected and to avoid any infections. The other things that we are not all agreed on is antibioprophylaxis. I know that in UK and Italy, patients are not receiving penicillin. We are giving penicillin in France. I think there is not a high, robust rationale for it. I guess that it's depending on experience of physicians. I mean, we have 2 young patients who died because of meningococcus infection in France some years ago, at the very beginning of the eculizumab arrival, and that's the reason why we thought that we could give all what we can to avoid any infection. So, I mean, it's probably too much, or it's, however, what the bodies were recommending. So at the moment, we are still giving penicillin in France. We are also giving folic acid because this is an hemolytic disease, so you need to produce blood to have some folic acid, and this is something that should be systematic. For iron supplementation, this is very discussed because some people are saying that this is something that might create hemolysis crisis, basically when the ferritin level is low, because again, you are consuming some iron when you are producing blood and of course destroying them. I think that you have to be supplemented. Finally, there is also something that is still discussed, is erythropoietin. We are not doing it quite systematically in France. We are giving it if the patient is presenting a kidney insufficiency, because we do know that then the EPO level is low and you have, of course, to give some. So I spoke about eculizumab, the indications, the way we are blocking the complement under eculizumab, and basically this is few slides, but it was really a revolution in the field in the last 15 years. However, what we did show is that eculizumab was not perfect. Of course, this is protecting against thrombosis, this is improving overall survival, this is also improving clinical signs and clinical symptoms, but we heard from that study that eculizumab was also still not giving complete hematological response. And that is the study that we did with some friends. There was Antonio Resitano from Naples. There was Austin Kulakasiraj from London, King's College. There was Rosario Notaro from Florence. There was also 2 Brazilian friends, Rodrigo Calado and Phil Steinberg from Sao Paulo and Ribeirão Preto. And basically what we did is to put, well, he was a student of mine, that puts 160 patients who were all sharing a history of hemolytic PNH. As you can see, they were all treated for a long time, 6 years, median time, by eculizumab. And what we did look on, it was the results. And as you can see, as it was the case under eculizumab, 80% of the patients received 900 milligram, but 17% were treated at 1200. And that was the description of the disease and the treatment overall worldwide. And as you can see here, the surprise was to see that only 20% of the patients has normal hemoglobin under treatment. And as you can see, there was about 40% of patients who had hemoglobin between 10 and 12, and the other ones being highly anemic and even sometimes transfused. So as you can see here, we all agree eculizumab revolutionized the field, saved life, protect thrombosis, but in the end, it's not giving you a complete hematological response. And that came to the point of what we could do to improve this hematological response. And we come back now to what I told you before on the complement cascade. If you remember well, I told you that the complement cascade go from top to down with an early activation, what we call the proximal level, and a terminal activation, what we call the terminal level. And basically, there is, of course, a continuous activation from top to down, but there is some way where you can inhibit the complement at the terminal level or at the proximal level, meaning at the late stage or at the early stage. So we are still developing drugs who block at the late stage. So there was eculizumab, now we have ravulizumab. I didn't even put slides on ravulizumab because honestly, this is exactly the same than eculizumab. The only difference, which is important when you're a patient, is to be injected every 2 months and not every 2 weeks. There is another drug that has been developed, and I'm sure that some of you already saw the press release from Roche for crovalimab. It is a sub-Q monthly injection of C5 inhibition. But again, I'm not so enthusiastic because it's not going to bring anything. It's not going to change the hematological response. Of course, it's going to change possibly, I would say, the horizon of the drugs, because we may imagine, even if it's Roche, that they will cover other countries, and that's what we want to see. But in terms of hematological response, it won't give anything more than eculizumab and ravulizumab. So I just remember you that, as you know, the only way to, I would say, improve the hematological response would probably be to block proximally at the early stage, very early on, the activation of the complement cascade. So that's now that we are turning on the future in what I would call the proximal blockers. So let me just come back to this. This is a bit complicated, I agree, and I'm sorry for this. But as you can see here, if you follow me, this is exactly the same representation than this one or this one. Exactly the same. You have up the proximal level of activation and down the terminal level. And here you see where eculizumab is acting. It's acting at the terminal level. It's blocking the terminal phase. It's avoiding the terminal activation of the complement. But as you can see here, the early phase of the complement is still working. And you can see here that obviously what happened with complement in blood is that when the complement is activated, the first thing he's doing is to fix himself at the cell surface of the red cells, you can see here. And this is already participating to the destruction of the cells in the spleen and the liver. That's what we call extravascular hemolysis. As you can see here, those cells, first of all, are fixed at the cell surface and are destroyed in the spleen and the liver. While when the process is continuing and the cells are still activating, some of them are going to be protected at the C5 level. And then we basically say that 70% of the cells are going to be protected by eculizumab, but 30% of them are going to be destroyed in the macrophages because they are protecting in the blood, they are protecting intravascularly, they are protected, but when they are in the blood, they are not destroyed, but because they have this C3 coating at the cell surface, they are going to be addressed in the liver and the spleen and being destroyed. That's the reason why the hematological response is not that good under eculizumab. While now we have the development of proximal blockers. So now you better understand blockers who are able to block everything. So basically, they are able to block the early and the late stage activation because they are acting at the very beginning of the activation of the complement cascade. And there is 3 drugs at the moment that are in development. There is pegcetacoplan, Aspaveli, the anti-C3. There is factor B, iptacopan, that is blocking at the factor B level. And there is factor D, danicopan. 3 pharmaceutical companies, Alexion, that has danicopan, Novartis, that is iptacopan, and Apellis, who is developing pegcetacoplan.
I'm not gonna enter into details of the level of blockage because it's not interesting. The only thing that you have to understand is that we are blocking at the early phase of the complement. So the complement is not present anymore at the cellular phase. So basically you are avoiding, of course, the intravascular hemolysis, which is the activation of the terminal phase, but also the extravascular hemolysis, which is the activation of the early phase. And if now we go to the scheme I showed you before, you see that we are blocking proximally. We are blocking the early activation. We are blocking completely the complement cascade. So what are the results of those drugs? Well, I think that you saw this paper that came out in the New England Journal already 2 years ago, when we compared patients who were receiving eculizumab or pegcetacoplan. So we're comparing a terminal cascade versus proximal cascade. And as you can see here, after 16 weeks, there was a huge difference in terms of hemoglobin level, with patients being at 8.6 grams per deciliter hemoglobin for patients who received the standard of care eculizumab, while patients who were receiving pegcetacoplan were presenting 11.5 grams per deciliter hemoglobin. So that's important, right? That's important. And again, even when we are discussing anemias and consequences and fatigue and so on, we can believe that the patients at 3 grams deciliter more hemoglobin level is doing better. So afterwards, we of course followed those patients long-term to see if this benefit, hematologically speaking, was maintained with time. And as you can see here, after the 16 weeks period of the trial, all patients received, 80 patients received pegcetacoplan. And you can see that all patients under drugs increased their hemoglobin level, showing that these drugs was benefiting to all patients of the trial in the extension phase, and that all patients have a sustained hemoglobin improvement during the study. And that was very important. However, what we have to be careful about is a number of patients in this long-term follow-up study who stopped the drugs because of complication. And as you can see here, there was 6 patients, 3 in the first 16 weeks period, but also 3 in the 48 weeks more period, 1, 2, and 3, who stopped pegcetacoplan because of hemolysis and came back to eculizumab. So that's important because it's 6 out of 13, so 50% of the patients. And of course, we were discussing why, and we found that those patients were exposed to higher rates of complement activation, breakthrough, and so on. Now we're understanding a little bit better. We know how to manage this breakthrough, and really we did some improvement. But this is something that we have also to take into considerations when we are changing patients' treatment. The second treatment I was discussing and presenting to you is iptacopan. Iptacopan is also blocking at the early phase of the complement cascade activation. And this is exactly the same level. This is a proximal blocker, but more. This is an oral drug. It's a pill that you are taking morning and nights. And as you can see here in those proof of concept study, all patients were transfused before receiving iptacopan, and after the treatment, no patients were transfused. So all patients were transfusion independent under oral iptacopan, and 5 of them in monotherapy, so with no eculizumab anymore. And that was the rationale for the development of this phase 3 randomized study, international study, that I presented at ASH this year as a late-breaking abstract. And basically what we did is to compare 30 patients, approximately 30 patients who received standard of care eculizumab with 60 patients who received iptacopan. And what we saw in that study is that iptacopan was able to give rise to transfusion independence in almost all patients, and to improve hemoglobin level to 12 grams per deciliter or more in 70% of patients. So outstanding results, monotherapy, oral drug. Those patients were only patients who were refractory to eculizumab, but we have another study in patients who were never exposed to complement inhibitors. It's the POINT study. It was a phase 2 study. It's a phase 3, but in the end, it's a phase 2. 40 patients, naive ones. And what we observed in that trial, it was patients gain in less than 8 weeks, 4 grams per deciliter hemoglobin, positive results, and that will be presented in Paris at EBMT in 2 months from now. So the next drug is danicopan. I told you this is Alexion. And as you can see here, again, you see all those red spots that were indicated transfusions before treatment. And you see that after only 1 patient received 1 transfusion. So it was outstandingly efficient in patients. And that was turning out in increased hemoglobin level. However, the bad things of this treatment, it's an oral drug, so it's a good thing. But the bad thing is that it has been developed only in association with eculizumab. So it's not monotherapy. So basically, you don't want to take 2 treatments. So that's the reason why I find it a little bit less interesting. So now let's come to another side, another field, biosimilars. So what I can tell you is that biosimilars are extremely active at the moment because the patent of eculizumab is sold out. So basically, other drugs came in. And there is 2 companies that are first for this, Amgen and Samsung. It's only eculizumab because the patent for ravulizumab will be in 2024, even more, 2025. What we are hearing in the corridor is that it might be a discount, a significant discount, about 30% at least, but this is something that at the moment is not official. And the other thing that might be outstandingly important that we've keep in mind is that it would probably be possible for some patients to have those treatments accessible in countries that cannot offer eculizumab or ravulizumab. The last thing I would like to speak about, obviously, is this international academic effort, the ePAG PNH registry. As you know, until now, we had a multinational, international PNH registry that was founded by Alexion. And as you may imagine, it's very difficult to be completely independent when a company is funding only a registry. So we decided as an academic effort to put a single registry with the help of the patients to have a single academic registry funded by all companies, to be completely independent, of course, to foster publication and to be able to analyze and to compare drugs between themselves to see which is the best one. So this is something that is arriving right now, and we'll see if it changes the field of the complement inhibition. So that's the conclusion at the moment, but obviously I would be more than happy to discuss. We came from eculizumab, ravulizumab was a standard of care who changed our life and your life with protection from thrombosis, overall survival, and so on. But what we learned is also that patients were still anemic under treatment. And if we want to obtain an hematological complete response, we have to come to proximal inhibition with new drugs, with a lot of competition, with pegcetacoplan, with iptacopan, also danicopan. And of course, this is rising up new questions. Those drugs are not available yet. But I think that we are living in a very exciting period in PNH because we may come in 2 to 3 years to patients who are just taking 1 pill per day, while 15 years ago, it was really a nightmare to treat patients with hemolytic PNH. And last but not least, you saw that there are some biosimilars coming in that also might stimulate the field. With that, I'd like to thank, obviously, all my collaborators in Saint-Louis and also at the international level that are participating to the study. Thank you very much for your attention. I will be more than happy to take questions.
Thank you, Regis.
Go ahead, Maria, please.
If I could start the questions off, if that's okay. You mentioned ravulizumab, and you said, I'm not going to say much more about it apart from that the infusions are 8 weeks instead of 2 weeks for eculizumab. But am I wrong in thinking that it also improved breakthrough hemolysis? So there were other advantages that ravulizumab had over eculizumab.
Yeah, so basically what we have to understand from the design of the trial is that ravulizumab studies were in a way developed like we were using eculizumab 1200. So in other words, we know that for the HUS, the hemolytic uremic syndromes, the dose that we have to use is 1200 every 15 weeks, every 2 weeks, sorry, and that in PNH it was 900. And basically, we know that 20% of our patients are increasing the dose during treatment because of breakthrough, because of recalling symptoms and so on. And so because of this, the drugs was designed as a 1200 equivalence of eculizumab. So what we are observing, of course, we have some reduction, but what we are observing is like we were using 1200. So I would say that some of the patients are feeling better, but they are still anemic. And yeah, it's not going to work on all the hematological response, but at least this breakthrough, I would say lower rates, even if it's not significant, is something that came from this dose adaptation. But it's important, right? I prefer to receive 1200 than 900, obviously. And just to be complete, to give you a picture, we have 60% patients in Saint-Louis who are treated with complement blockers at the moment online, and we have only 5 patients that are still under eculizumab. The other ones are in protocol or under ravulizumab, and in those 5 patients, we have 3 with acute conditions where we don't want to use more ravulizumab because we don't know when we can re-inject or so on. So just to say that at the moment, we switch almost everybody under ravulizumab, at least in France.
Thanks, Regis. So we've got a couple of questions in the chat. So Sally's asking, would you please speak a little more about crovalimab? Would this be helpful to patients currently receiving infusions who have difficulty in locating veins?
Yeah, obviously, I'm sorry not to be so enthusiastic about crovalimab. I can tell you when you are living what we are living with proximal inhibition, when you see some patients coming from transfusion dependency to normal hemoglobin level in 8 weeks, I mean, this is just amazing for physicians to see this, and the patients are really feeling better. So why I'm not so enthusiastic for crovalimab is that it's not going to change anything on the pathophysiology of the disease, so you will still be anemic. And I'm not convinced that it will change the transfusion status. If you're transfused under eculizumab, and if the retics are elevated, it means that you have a clinical symptomatic extravascular hemolysis. And the only thing that might improve your hematological status is a proximal inhibitor. So I'm not saying it's not useful, because as you are saying, obviously, when you have some veins problems, when you want to be away from some months, you can take it in your luggage. So of course, it's important to develop those kind of drugs. I'm just saying that it's not going to bring any hematological benefit in our population, more than eculizumab and ravulizumab.
Thanks, Regis. There's another question, but before we go on to that, there are patients who are, shall we say, do okay on C5 inhibitors and may not need C3 inhibitors. That's right, isn't it? So it's not everybody that experiences extravascular hemolysis. I don't know if you know the percentage of patients that we think do.
This is outstandingly important, and the message on my talk should not be, please go to your physician and ask for a proximal blocker. No. We have 60% of our patients that, of course, with some of them are still anemic, but are doing great under ravulizumab. So in other words, if you are feeling well, if you're not transfused, and if you have a normal life, I think it's not necessary to rush to have a proximal blocker, especially because for the moment we have few patients that has been treated. We need, some follow-up. And of course, we are very exciting as physicians, but we need time to evaluate those drugs. And as you can see, the 48 weeks for pegcetacoplan showed that some patients stopped it. So in other words, you're absolutely right. For me, the patients who should receive at the moment proximal blockers are those who are still transfused because of a clinical symptomatic extravascular hemolysis. And it's about 30% maximum, 30–40%.
Thank you. So Sylvia's asking, she's curious if complement is a natural process. Is it activated more in PNH, or is it that the activation normal lysis cells? Also, what do we know about the long-term effect of blocking a natural process, i.e. complement?
So in PNH, the problem is that we are not able to inhibit the complement activation. So basically, what we know is that the complement is activated in permanently, constantly. But at the cell surface, you have some inhibitors. And then, of course, your cells are not destroyed. The problem of PNH is that those inhibitors are not present, so the cells are destroyed. So the complement is not more activated in PNH. It's just not inhibited. And especially on red cells, because we have other inhibitor on platelets and white cells. So that's the reason why it's so obvious on red cells, because we don't have any other inhibitors. So you don't have inhibitors because of PNH. This is the rationale of PNH. This is you don't have those molecules, so you are destroying your cells. So the complement is not more activated. It's just because you cannot inhibit it as you should do as a natural and normal patient. So this is the first answer. The second answer, I mean, we don't know yet. And that's exactly the problem at the moment, is that for terminal blockage, we know we have 15 years of age of treatment. We have no evidence of higher rates of cancer, clonal evolution, such as CML, MDS. The treatment is safe. There is no complication. So blocking at the terminal level, there is no problem. And here we are, and Sarah is writing at the moment, is the fear that we might have, of course, more infections first, because we are blocking at the early phase, but there's no more autoimmune disorders, because the complement is participating to eliminate all the autoimmune cells or antibody, to make simple. So in other words, this is also helping yourself to eliminate all the cells that we are producing that are reacting against us. This is normal. We have alloreactivity, we have autoreactivity. This is totally normal. But the complement is participating to avoid this autoimmune reaction. So what we are a bit afraid of with proximal blockers is obviously a high rate of infections, a high rate of autoimmune disorders, and possibly high rates of cancer. But for the moment, again, there is absolutely no fear about that. All the data that has been produced are clean. But of course, we have to follow very carefully our patients to be sure that it won't be the case.
If there's no other question, I actually wanted to raise a question about that may be related to this topic. I was wondering if there are any side effects that have been observed in any of the inhibitors. I mean, both proximal and terminal. And also, well, that's another question then. Go ahead.
Yeah, so yes. So what we have observed is minor and major side effects. So the minor side effects are reaction at the injection site for pegcetacoplan. We have some red things that are appearing, nothing severe, and this is very something minor. We have also some idiopathic pneumonic syndrome, so idiopathic pneumonia, with at least 2 patients that has been described, one of mine. And we had some very symptomatic pneumonias. And when we stopped the drugs, then everything solved. So this is something major because we had to stop the drugs. We did not observe any, I would say, infections or other complications. And another thing that I was telling to you, it's not really related to the drugs, but it is related to the management of patients under the drugs. We know that patients under pegcetacoplan can go quickly badly. Mm-hmm. So in other words, for example, my patients under pegcetacoplan, they have my cell phone. And if there is something wrong, they don't feeling well, they have fevers, they whatever, they call me and we'll sit together and we do a sampling. We see if we need to increase the rhythm of injection, if we need to go to transfusion, to an extra dose of eculizumab. Now we know how to manage. But at the beginning, we thought that we had time. The problem is that under proximal inhibition, you have patients with, I would say, almost 100% PNH load because all cells are protected. So if there is a problem, when you're under eculizumab, you have 70% of PNH cells, but you have 30% of non-PNH cells. So you're not decreasing from 13 gram hemoglobin to 8 or 5. You are decreasing 2 gram maximally, 2 or 3. When you're under pegcetacoplan, since all your cells are protected, when it's not working anymore because of infections or whatever, you are coming from 13 to 5. So that's the problem. So that's the reason why we have to be very careful. So this is for pegcetacoplan. For iptacopan, we got some abdominal pain, diarrhea, rash, but not severe.
Okay.
And more importantly, we did not have any single patients under a 26 weeks period of time who stopped the drugs. There was one patient who stopped because of pregnancy. And since we don't have any follow-up on pregnancy under iptacopan, so we stopped it and come back to eculizumab because of pregnancy. But we didn't have severe adverse events that make us stop the drugs.
Okay, regarding pregnancy, actually, there was sorry, I interrupted you.
And the last one for danicopan, it's liver toxicity with mainly liver test abnormalities.
That's for iptacopan?
Danicopan.
Oh, okay, okay. So there's a question coming about pregnancy. What would you recommend to someone who's trying to become pregnant and is currently on pegcetacoplan? Would it be a high risk to stay on this medication when pregnant?
So it's a very good question. I would say that at the moment, we don't have any background feedback and data. I know one patient who had the pregnancy under pegcetacoplan. I know 400 under eculizumab. So in other words, we have a robust background of patients who had a pregnancy under eculizumab. And at the moment we are speaking, I don't know that it won't change in 2 years of time, but at the moment we are advising to go to eculizumab to be pregnant because we know exactly how to manage the drug during pregnancy. We know that it's not toxic for the kid and not for the mother. We know how to manage it, to increase the dose at 6 months, to manage the anticoagulation. We know all this. So for me, it's far more comfortable to do all this under eculizumab. But because, again, we don't have any data on proximal inhibition in pregnancy.
Okay, so you would basically recommend for someone who's thinking about getting pregnant or becoming pregnant in the future not to go on pegcetacoplan as far as they can see.
Or to come back to eculizumab while being on pegcetacoplan. Yes, that's what we are doing.
And is there anything you need to watch out for when you step back on Ravu or Eco? What do you do?
We have really to be careful from proximal inhibition when you come back to standard, to be careful from the 2 first months that you can create some hemolysis. So you have to be highly hydrated, follow up carefully by your physician to see what's going on. Because as I was telling to you, we are coming from a complement blockage with 100% PNH loan to a patient that is 70% blockade with a mixed hematopoiesis of PNH and not PNH.
Thank you.
And you need time to do to this equilibrium.
Any other questions?
Sorry, my internet threw me out, but I'm back. Regis, can I ask you, iptacopan, that sounds quite promising, obviously from a patient point of view, taking an oral tablet rather than an infusion or a subcutaneous injection. How far away do you think we are from that sort of being available to patients?
2 years. No, I will be more precise. So basically, what we do know is that once you got EMA approval or FDA approval, you need about 1.5 years, depending on the countries. For France, it's 2.5 years to get the drugs in the country, because you have all those discussion, pricing, and medical improvement discussion with bodies, and that's it. So at the moment, the file is not approved by FDA and EMA, but it's almost, they are doing the process, and it's not a secret. So it should be ready, I guess, probably this year. So that's the reason why I guess on the regular process, it should be available in 2 years of time. And there is another way to access the drugs is the early access. And there is many countries that are authorizing early access, especially because of the oral statement that makes you coming early on the market. So I would say that on a regular basis, it should be available in 2 years, 2.5 years. And on an early access basis, it should be 1 year.
And if I may add to this, if EMA accepts this and approves, in Germany, it would be available quite straight away.
Yes, you are lucky enough to have access directly to treatment. That we are not.
So just for the German patients to know.
And there's another question from Sylvia in the chat. Can you expand on the controversy of using antibiotics? Who does and who doesn't as part of PNH management?
Yeah, you know, it's a never-ending discussion, because we all have our backgrounds, of course, scientifically speaking, but also in practice. I'm a transplanter from the beginning. 80% of my activity is bone marrow transplant, and I can tell you that some of my patients are under antibiotics for years. And I never saw any single patients developing resistance or whatever while receiving penicillin, basically. It's very safe, it's very well tolerated. And what we can say is that meningococcal infections, pneumococcus, are highly sensitive to that treatment. So on one side, you have this background, and on the other side, you have, of course, infectious disease people that are saying that less you are taking antibiotics, much is life is better. So it's a never-ending discussion. I think that obviously, when you saw patients dying because of meningococcal infections under eculizumab, you want to offer the best protection for your patients. So obviously, you have vaccination. But what about vaccination under a patient that is under eculizumab? Because this is a complement blocker. And if you are vaccinated patients, is to use antibodies, and antibodies to work need complement. And if the complement is blockade, so how it works? So basically, this is also because of the thinking that the action of antibodies are not optimal under complement blockers, that we think that it's not I would say, optimal protection. But again, when you look for the registry, there is no more deaths in UK or in Italy who are not advising antibioprophylaxis than in France. That's the problem. So I may, of course, elaborate, but in the end, I will come to the point that it's more on, I would say, practice than on scientific evidence.
Can I add to that? Do you know if there's any research being done about long-term use of prophylactic antibiotics? So has, for example, it increased antimicrobial resistance for other infections because of the long-term use by patients with these antibiotics?
Yes, that has been done in transplant setting, and we didn't have any problems when you are not using, of course, large spectrum antibiotics, but it has not been done in PNH. And the other thing that has not been done quite nicely, or I would say scientifically robustly, is to look if the antibodies under complement blockage are efficient in our patients. We know that half of the patients are responding to vaccines, half of the patients. So we don't even know that all patients are protected. And that's what we know. But no, there is no well done research on this. That's a pity.
And maybe, can I add something to this? Because the German patients may even not be aware of this, that in other countries, people have under complement inhibition, they take antibiotics frequently, usually. And in Germany, they don't. They just have a, I think, 1,000 milligrams of
Ciprofloxacin.
Yeah, thanks. With them, to carry with them, like in such a thing here, like a thing that you can carry on your keychain or something, and you can put the medication in it. And you are educated on the symptoms of meningococcal infections, so that you know, in case you have something like that, you react very quickly and take the medication, and then you're advised to go to the ER straight away.
Yeah, this is another possibility.
Does anyone else have any other questions? Regis, can I ask, while other people are thinking about their questions, why do we think for an ultra rare disease there is so much drug development activity going on in PNH?
Yeah, of course. It's because PNH is a prototype of complement mediated disease. So in other words, there is no interference of genes or any other environment factors, infections, inherited disorders. So in other words, PNH is the perfect disease that if you want to test the complement inhibition to see if it's working or not. So that's the reason why companies are so active in this disease. But in the end, of course, they're not naive. And if they had some good results in PNH, then they're expanding to the other 200 complement-mediated disease to develop the drugs. And as you can see, now ravulizumab has been developed in neurology. There are some drugs in nephrology. They're exploring some autoimmune disease. So that's exactly why companies are coming to the field.
So there are many other conditions that are affected by complement or interfered with by complement, and they're using PNH basically to test their drugs so that they can then change the indication.
Exactly. Okay. Because you can see it's big companies. It's Amgen, Samsung, Roche, Novartis, Alexion. So yeah, they have something in mind.
Mm-hmm. And I think it's interesting also to mention that obviously we don't have the exact numbers, but approximately 70% of patients around the world have no access to any treatment at all, apart from what we call supportive treatment, which would be like blood transfusions. And that is because the price of these treatments is so expensive, which is why biosimilars, which you mentioned before, which people might not know a lot about, are so important, maybe not for countries where we have access to these treatments and we're lucky enough to have that, but for countries where patients potentially are dying. So we could be in a position soon where we're all taking a pill twice a day, but there's a huge group of patients around the world who have absolutely nothing. So can I ask you to go into a little bit more about biosimilars? I think people might understand the copy of a generic drug being a copy, like paracetamol has copies, but a biosimilar is similar for a biologic drug. Is that correct?
Yeah, you are fully correct, and I should confess that for me, it's I would say the worst difficult part for a physician when you're developing drugs in a very rare disease, because of course we are saving lives in our countries. We are trying to reach a complete hematological response. We are including patients into protocol to have the ITOP
And just to say, we are obviously the patient community, patient advocacy community is working hard with you and other clinicians as part of the EuroBloodNet network. So as Regis says, there are patients that come to the PNH Global Alliance from all over the world who basically have no treatment and need help. And we try and help them as much as we can. If they live in Europe or near a European country, it's easier because of the cross-border health regulations in Europe. But we do try and help. We've had a patient from Guatemala who contacted last week, and our member from Spain is helping them. We've had a Moroccan patient that we've been able to also try and help as well. So access to treatment is one of the main aims of the Global Alliance in terms of trying to address this, because as much as many of the Global Alliance members all have access to treatment and their countries do, we're very aware that that's not the end of the story. So we need to be basically using our position of privilege to help patients in countries that have no access. So really important topic. Pascale, did you have a question?
Yeah, well, maybe let me just add to that I think the European patients that have access to treatment shouldn't feel guilty about this, but they should be aware of their privilege as well. And if they can help other patients in the future to receive treatment in any way they can, and that may be just engaging themselves for it. And I have another question for you, Regis, and I hope I can articulate myself properly in that. It's about fatigue. I mean, we know that over around, I think, 85% of the PNH patients report fatigue. And I would like to ask you if there is any idea of how fatigue actually developed, because there used to be a saying that it's just correlated with hemoglobin level, but this has been not completely right, I think. It does not necessarily correlate because now we see people on higher levels of hemoglobin and still suffering from fatigue. And I was just wondering if you have, well, I have my own theories, but if you have like an idea of what fatigue could be caused by.
Well, I think this is most difficult symptoms to address in a patient. It's very varying from a patient to another. I'm still convinced that PNH is a autoimmune disorder, and that when you have even a complete remission, you are not, I would say, cured from PNH. So what I'm always saying to my patients is that, of course, you are feeling better. I mean, those ones under proximal inhibition, they are feeling better because of the hemoglobin level, but the hemoglobin level per se, I fully agree with you, is not a good indicator for being not perceiving fatigue. So I'm saying to my patient that yes, the disease is still active, and it's not something that is obviously related fairly by hemoglobin level. And then outside a curative approach, you may have fatigue even if you have a hemoglobin level that is normal, especially because, again, this is a complement disease, and there is many patients, and we see this more oftenly in the proximal inhibition. You have very variation, even if you're not feeling sick, you have no fever, but the only thing that you are feeling is fatigue. So what I would say is that those patients might be a little bit more sensitive to viruses and stuff, because we are not living in a sterile world, in a clean world. We have germs everywhere. So I would say that since you're still being sick, even if your hematological response is good, you're exposed with a less reserved, you're exposing your body to infection and so on. So the disease is still active, and in the end, it can cause fatigue. That's what I'm trying to explain to my patient. Oh, you're on mute, Pascale.
From my point of view, I would like to say that if you just said, even if you're not feeling sick, you have fatigue. I think if you have fatigue, a lot of patients feel actually sick, but the physician may say everything is okay, your hemoglobin level is okay, your LDH level is okay, and you shouldn't really feel this way, and they still feel fatigue, which is a feeling of sickness, really.
I agree. I agree. I'm not saying that we should convince the patient he's not feeling this fatigue. I'm just saying that since everything is okay, and since the patient is really expressing himself with this sensation of fatigue, there is something else. And that's the reason why I was saying that basically, even if everything is okay, it's not because of this that in your body, in your marrow, the complement system is not activated wrongly, because of good reason. I mean, if you have a PNH and you're facing a virus, you have to eliminate it, but you don't have the good arms, the good weapons to eliminate it. So you're, of course, your body is trying to fight it in other way, and that, I think, is causing tiredness. So that's what I'm trying to explain to my patient, because I have, even in aplastic anemia, I have many patients after immunosuppression with stop cyclosporine, and they are all, or most of them, a large part of them are saying, well, you know, I'm still facing fatigue, and I don't know why. That's what I'm trying to explain, but I mean, I don't know if it's true, and I don't have any, you know, good marker of it. But the autoimmunity is still in if you have not been transferred.
Well, that's basically what I think, and what my theory would be like, that it's partly disease activation itself, and it could be medication as well in any way, like people on cyclosporin may feel fatigued by that a little bit, and there's other things that can cause it. So it's multifactorial.
And it's true that when you have been transplanted and the things are doing well, I mean, patients, when they are, of course, far from the transplantation, outside any immunosuppression, I would say they are not feeling so much this fatigue. It's different.
Mm-hmm. Yes,
And,
I can support that.
Of course, they have consequences in their body about treatment, but it's not the same thing. So that's the reason why I really do think that even if the disease is controlled, the activity of the disease is not controlled completely. And even if you're not seeing it, it's still present, and that might explain the fatigue.
Yeah, I totally agree.
But it's difficult to find some objective markers, to find some, things that might really objective it. So that's the reason why it's very difficult.
Yeah, it's very difficult, but we're on our way. And that's why it's very important to use good questionnaires for quality of life and fatigue as well. And we're getting there.
Yeah, I have a patient that is a policeman. And she was under eculizumab, she was highly transfused, so she entered into the iptacopan trial. Now she's 12 gram hemoglobin. She was transfused every month. Now she's 12 gram hemoglobin. And she's still saying to me, I'm experiencing fatigue. Mm-hmm. And that's what I told her, and so on. And then her chief wanted to fire her because it was not something she was looking. She was not, you're not looking like fatigue. You're not looking like out of hair. You're not looking like cancer with chemotherapy. You're looking well, right? Mm-hmm. And I had to write to this work physician to say, well, I know you're not seeing what's going on, but this lady, she has a PNH. She has been transfused since 10 years. She's in the protocol, experimental treatment. She might have a normal hemoglobin level. She might have a normal physical exam. But if she said she's experiencing fatigue, this is true. And it was a hard fight. So that's something that is really very difficult to face for patients. It's very difficult to face for physicians also. It's a real problem.
Thanks for explaining that, because I think that's a real problem for a lot of patients.
Yeah, I agree. And sometimes, I mean, the position of the physician is not the good one, I would say. Most of the time, it's what you were saying. I mean, the counts are okay, right? The values are okay, so you should not be experiencing fatigue. So it's not true. While, I mean, sometimes just, trying to find another reason, again, we are not curing disease, we are controlling symptoms. This is very different. And that's the reason why when you're a transplanter, you see both sides. I'm not saying transplant is not something that is causing fatigue. I'm just saying that in some patients that are doing very well after transplantation, when the disease is cured, those patients are doing far better than patients under complement blocker.
Yes.
But Regis, just to qualify, transplant isn't recommended for PNH treatment when there's no other underlying bone marrow issue, correct?
Completely agree. It's forbidden for patients with thrombosis, forbidden. And for patients with hemolytic PNH, I mean, the overall survival is 85%, 5 years. So it means that you're already losing 15% of your patients indicating transplants on those indications. And afterwards, you have 50% of the patients who are presenting chronic GVHD. So it's not a good treatment when you have complement blocker excess. When you don't have complement blocker access, and you know that before eculizumab was available, the overall survival of patients was 22 years, means that when you were diagnosed at 30 years, half of your population were not there anymore at 50 years, then you can imagine that for those countries, transplantation might be a solution. So we have to be careful again in the wording. In countries that might offer complement inhibition, there is no place for transplantation hemolytic PNH. For the country where we cannot, it's another story.
And to just go,
oh, sorry.
you know, if there are any other questions, please people write them in the chat or put your hands up or ask them. Just to go back to what Pascale was saying about this issue that we have with fatigue and how hemoglobin doesn't necessarily correlate to how we're feeling or isn't a good marker. We're hoping with the PNH registry that we might be able to look into that, I'd imagine, a bit more. And because that registry is going to be collecting data from patients on all types of treatment as well as no treatment. So I think that might be able to give us perhaps some insights into maybe there are slight differences between some of the treatments and how patients feel on them. So for example, maybe some patients aren't feeling as fatigued on one treatment over another. So those will be quite, those will be very interesting insights for patients to understand, I guess, as well as physicians. And maybe that data, that registry data will allow us to look a bit further into this fatigue issue, which we know isn't just tired and heaviness. For some of us, it's cognition and memory difficulties and brain fog, which I know has been talked about a lot more in relation to long COVID. So we've talked about brain fog for many years, but now brain fog is kind of much more of an acceptable term because long COVID patients have experienced it. But all of those things, I think, hopefully we'll be able to look into in a lot more detail with the new PNH registry that Regis mentioned, which is sort of on the brink of starting.
Yeah, I fully agree. But again, I mean, physicians have some difficulty to consider symptoms that they are not seeing.
Yeah, and then I think also patients are not even aware that some of the symptoms or issues they experience are related to the disease or to fatigue. Like cognition, a lot of people think, oh, it must be age, or it can be age, obviously, or some doctors say a patient may be depressed and it might be a depression, but I think a lot of times it's also the emotional suppressedness of the fatigue, which kind of brings you to a listlessness or makes you very, you know, feel very heavy and not enjoying things because they're just stressful for you. And that's something that is quite hurtful for patients when they go to a physician and they're being told, oh, you might have a depression, but it's nothing related to your disease. So I think this is something that needs to be assessed quite well as well in the future, and I hope for that.
Yeah, I agree.
Anybody has a comment on that?
Oh, I do. I think that depression is definitely associated because it is not fun dragging your heels through every single day and being unable to manage just a regular day because of the fatigue. And that wears on a person. So I think it's not uncommon and I would say quite understandable to be depressed. So you get
yes. I'm sorry, Sylvia. I didn't mean that patients don't have depressions. They do, but then you can treat that much better than fatigue, actually. And it has to be distinguished quite well. And of course, feeling so fatigued and being that ill as well can lead to depression. I fully agree with that. And nobody has to be ashamed of that. In the contrary, it's just important to distinguish those two things. And some people don't feel the depression, but they feel very fatigued, and physicians say that. But if you have a real depression, it should be treated, and obviously you should talk to your physician about it. Fully agree.
Yeah. Yeah.
Sorry, can I ask one question? I know we've talked about treatments of PNH, and you focused on that, and it's been very, very interesting. Have we seen, or from your experiences, have you seen any patients that have gone into remission where they no longer need treatment for PNH? Or
Yes.
Yeah.
Yes.
Okay.
Yes, we have 1 to 2% of patients
Yes.
are showing a decrease of their clone, coming back to very low level. And I remember perfectly one that is 26-year-old, is treated since he's 19, and he had a 70% clone with hemolysis, LDH, and so on. And basically, the clone decreased under eculizumab. Under eculizumab, he was okay. Then ravulizumab, he decreased, and then he was at 1-2%, and he has no hemolysis symptoms anymore. And we stopped, and he's doing great. So that's the reason why we should continue to test the PNH clone under treatment. And basically, I really encourage our physicians to do it at least yearly, because I mean, you are giving expensive drugs to our patients, with some patients that need to be injected regularly. And yes, you may have a disappearance of the clone. That's P. Tillman who described it firstly. This is the first part of the answer. The second part is that we don't know why. And that's the most frustrating.
Oh, okay, thank you. Also, with a high clone, PNH clone, is there any particular reason why people have a higher clone than a sort of, very high? So you're literally at the top, say, 98%, things like that. Does that have any medical significance at all? Or is, once you're above, say, a certain level of a PNH clone, does it make, if you go from 60 to 100 or whatever, does it make that much difference?
Well, I would say that overall, there is not much difference. You have patients with hemolytic PNH, they have a high clone size, mainly more than 50%, and then you have a proximal inhibition on one side, and you have 90% clone, and you have a terminal inhibition, so proximal new blockers, terminal whole blockers, and you have 90% on one side, 70% on the other side. This is always quite the same. We don't have any, I would say, patients who are reaching the ceiling on one side, and the group of patients in both sides are all almost the same. We don't have any clues to say that this one, because he has this, he has a higher clone size. It's all the same.
The other thing you mentioned about penicillin. I'm in the UK, and I've taken penicillin literally from the day I was diagnosed with PNH. So I've been taking it for 17 years every day. So just to let you know, there are some people in the UK who have taken penicillin continually, and also folic acid as well.
And you are feeling well, right?
Yes, very well. Yes, I'm on ravulizumab now, and I'm feeling as well as I have felt ever since treatment started. I've had great praise for the physicians in the UK, and also for the likes of yourselves promoting and researching into the drugs and helping our treatment. Yes, I've got no bad words to say. It's been, a lifesaver for me. I play a lot of sport, golf and things, or if you call snooker a sport, I've played today. So yes, I get about and I do things, and I try and lead a normal life. And I echo your comments you made about an employer, not taking account of people's fatigue. And I have been on the end of that, where I've been in employment and I've felt fatigued, and it's resulted in a job loss, unfortunately. But those sorts of things, I think, can only be overcome by educating people, and also with the help of yourself. Again, I've had assistance with other jobs and things where I've got assistance from physicians writing a letter and things like that. So I think those things are very important. It's important that PNH patients, etc., are given the opportunity to lead an as normal life as possible. And that's what I've tried to do. So I thank the likes of your good self. Thank you.
Yeah, you know, I mean, as a patient, I know it's very difficult because it's a rare disease and you are facing many physicians who are taking care about many other hematological disorders. And I see, because it's exactly the feeling I have when I see my patients facing other physicians. They don't know PNH. And of course, they are not considering the disease the way it should be considered. And this is very frustrating for us as experts like Austin, Antonio, and others, because we do know what you are describing is not fake, right? We do know that when you have a large cohort of patients with PNH and the complement blockers, that even if you have a normal hemoglobin, you might feel fatigue, and it's not something you're inventing. It's just because everybody is saying the same, so it's true. But the thing is that it's a rare disease, so you don't have so much experts. You don't have so much physicians who have more than 2 patients. And so, yeah, I feel again guilty. I'm sorry, Pascale, I will say this twice. But it's true because in a way, you are representing a community. And when you're a physician, you cannot believe that some of your colleagues are not considering our patients the right way. So, you know, that's part of the job. I mean, I was, when I was younger, I was highly technically, I was really believing in papers, you know, very robust stuff. And then when you grew up and take a little bit of you know, just out of the things, you see that, yes, there is also other things and things that you're not understanding properly when you're young, but also when you're not facing this kind of disease. So I can just apologize for those feelings that you may have with patients, with physicians who are not considering the disease the way it should be. And of course, we are trying to educate, to communicate, to explain, but it's not so easy. And since it's a rare disease, we're not so interested, you know, in our colleagues because they are not facing patients. So it's not easy.
Yeah, thank you.
I'll just say that it's really been reassuring to hear you speak like this, because I had fatigue that was, I don't know if it was inexplicable. I was also transfusion dependent, but the fatigue was, I always felt like it was, for many, many years, I felt as though, you know, I was just weak. And I should be, you know, I should be doing better. And now that I'm on a different medication and I don't have fatigue, it's completely different.
Yeah, thank you. But again, I mean, the problem is a rare disease. It's not well known, and we don't have so much time to see patients at the moment. We are with low resources, and people are just looking on results, not on people. They're looking on counts, CBCs, LDH, kidney function, but not the rest, which is a pity. I'm not saying it's good, but yeah, it's the way it is.
Thank you very much. I have, unfortunately, the uncomfortable role of stopping this great debate. It has been really amazing. I'm wordless. You have really touched all the aspects of this topic, from ethical, I would say, to clinical, to regulatory bodies. It has been really, really amazing. Thank you very much.